So thank you everybody for joining us in this very few last minutes. And I just wanted to present what we did in intensive care in Sweden for the first 2 months of the pandemic, when there was really chaos and nobody really knew what to think about this disease. And this is a study that we put together because really we knew very little about the outcome of ICU patients. It was splattered all over the media, not enough ICU beds, not enough ventilators, patients are dying like flies. And in fact, we didn't know what was going on. And with the few results that were available at that time, as Johnny pointed out, and as Friedrich pointed out, and also Jens, there was very variable coverage, but also very variable quality in the data that was reported. And some of these reports were in the Lancet and the New England Journal of Medicine. And that's what we had at the time, and we had to make do with that. So the mortality of ICU patients ranged all the way from 16 to 62 patients, 62%, but there was a huge bias. The majority were not discharged at follow-up. So by the time that you counted the patients who actually died, most of them were still in ICU. So that gives you a large reporting bias. And in fact, until the middle of September, we had no national data at all about COVID. And then, of course, there was this controversy regarding the relaxed Swedish strategy. We didn't have lockdown, and therefore we were all going to end up in hospital and in ICU. So we decided that we would study this. What are the facts? And we put together a team that I'm very proud to highlight, because we really tried to be inclusive. We included medical students, we included representatives from the Swedish Intensive Care Registry, we included the Folkhälsomyndigheten, the Swedish Public Health Agency, and we included preclinical researchers as well. And I just want to share with you some of the very, very basic data. Basically, ICU patients in Sweden were not different to any other population that have been published. We were exactly the same as the Chinese, we were exactly the same as the Italians. We weren't older, we weren't younger, we weren't sicker or anything like that. About 61 years of age in general. This is 1,563 patients, just at the peak of the pandemic, mostly males. The SAPS-3 score is a scoring system that tells you how sick people are when they get into ICU and they were sick. The SOFA score is a score telling you how many organ failures you have. And of course, as in every other data that has been published, most of the patients had a heavy comorbidity load. The PaO2 FiO2 on ICU admission is something that says, that tells you about how hypoxic patients were, so how much, what the lack of oxygen is in their blood, and 13 is a very low number. And in fact, that is one thing that sets the Swedish ICU population apart from other ICU populations. Our population were really quite hypoxic by the time they got into ICU. The other thing that was also interesting is not very many people got specific COVID-19 therapy, and by that I mean the drugs that we are using to treat COVID specifically. And at that time it was hydroxychloroquine. You will remember the whole issue with Donald Trump taking chloroquine and buying it off label. We also know that a significant proportion of ICU patients were transferred, nearly 27%. I'll come back to that later because this is interesting, and this doesn't usually happen in other countries. Acute kidney injury, the reason why I bring it up is because this is something that happens to you in ICU. It's not something that you necessarily come with, but this is organ failure that's developed in ICU, and that was nearly 50% in the early stages of the pandemic. So the bottom line was that ICU mortality, when you followed up all the patients until discharge, was about 23%. And when you followed them up for 30 days, because they usually stayed in ICU for about 2 weeks, the 30-day mortality was nearly 27%. So the majority of people who died in ICU. Now, Jens also presented a multivariable analysis, and this is our multivariable analysis. And what we did was we tried to make some sense of the data. What are the most important factors? Once you ended up in ICU, what are the most important factors that contribute to death? So if you were older, if you were male, if you're a little bit sicker on admission, you were more likely to die. And that is not something that is so surprising, but it was important for us to have a confirmation of that. The other interesting thing about this study was that the contribution of comorbidities, which was being so highlighted in the media, was very small. Really, only chronic lung disease was independently associated with 30-day mortality. Now, it's not the same as saying that hypertension and diabetes and obesity and all those other things are not associated with mortality. They are. It's just that when you throw them into the bigger model, when patients are already sick and have all these other factors, then the contribution of those comorbidities becomes less. Specific COVID-19 therapy at that time, it was hydroxychloroquine, was associated with an increased risk of death. And the other thing that I wanted to highlight was this AKI, acute kidney injury, something that is preventable in ICU, was associated with an almost doubling of the risk of death. So basically, the main message that we got from our study was that we're lucky. We are lucky in Sweden. We saw generally lower mortality rates than what has been previously reported. I also wanted to highlight the role of or the diminished role of comorbidities. I'm not saying that it doesn't have any bearing. I mean, comorbidities do increase your chance of getting sick from COVID, but once you are in ICU, their role in determining mortality becomes so much smaller than everything else. And mortality was in fact driven by the presence and degree of organ failure, and especially respiratory and kidney injury. The other thing that surprised us in the study was a signal for harm. If you treated patients with chloroquine, there was a signal that the patients could be harmed by this. So I think those were the lessons that we learned in the early stages of the pandemic. And of course, there were there was some media attention to this. Some of it was positive, what can we learn from Sweden? Some of it was neutral. How do we apply these results? And some of the other media attention were not so positive. We were accused of cherry picking the patients that we admitted to ICU. And of course, that is not the case. And we have data to back that up. So that was our study. And of course, we will continue with the same team in future studies. We now have a year of experience behind us, and we do want to study the larger cohort. And in fact, in the second and third wave of patients, we have had more COVID patients compared to the first wave of the pandemic. And as Jens says, a larger sample size will allow a more robust handling of confounders. We also want to know what happens to these people when they are home from ICU. If you have managed to survive intensive care, what happens when you get home? What is the added healthcare burden? Can you go back to work? This data I just pulled out of the Swedish Intensive Care Registry, and this is a 30-day mortality. This is from March 2000 and here up to February 2021. And what you will notice here is this variability in mortality. Now, this fascinates me because I don't know why this is the case. Why should we be saying this huge variability in COVID-19 mortality? And it's not due to the extra all the British and the South African variants, because up to this time there was very little variance in Sweden. So we would like to study this. Perhaps it's an effect of case mix, or perhaps it's an effect of ICU load. Perhaps it may even be an effect of the treatment that we've been setting in. So this is just to allay any fears about the lack of bed space in ICU in Sweden. But because as you may have read, or I'm sure you've heard in the media, there was this huge uproar about the number of not just ICU beds, but the number of ventilators and doctors and nurses and other personnel that were able to operate these kinds of treatments. But really, even at its maximum on a national level, I'm not saying on a local level, because we did suffer locally on some days, like today, we didn't have enough beds, and then you're transferring people over the whole country, and this is why we had a transfer rate of 27%. But even at its maximum, we only reached 80% of total ICU capacity. Do drugs make any difference? The correct answer is I don't know. We think it does, but really we will need to study that, and only time will tell whether or not we did the right thing. And there are several small projects or smaller projects, they're not small at all, that we are embarking on in collaboration with other actors within CircM. One is with the Department of Clinical Physiology studying myocardial injury in COVID-19. We know that about 20 to 25% of ICU survivors have some sort of myocardial injury post-COVID. And then finally, we just want to know what the continued burden of disease is a year after you've been discharged and survived ICU. So from me, I would really like to extend my sincere thanks to each and every one of you. There's been so much focus in ICU, but let me say that you allow us to live and to work and to keep doing it every day. Thank you.